And again, I would like to thank to Dr. Vipul Chavda, Dr. Dhruvi Asnanim, and all Origin Committee for inviting me today's in conference. And the topic what they have provided me here to deliver talk on the despite newer oral anti-diabetic drug, AGI is still switchable or ready for India. See, we all know type 2 diabetes is a progressive disease, and there are a lot of the oral anti-diabetic drug available on the hierarchy of the management. And in the era of the GLP-1 RA and the SGLT2, still is a right choice as far as Indian patients? Yes, we all know the oral treatment of the diabetes is individualized, particularly in type 2 diabetes. Type 1, we all know there is insulin only the option. But still, in next 20-25 minutes, we will come to know we can consider AGI, amino glucose inhibitor, as far as the OD is concerned when you are going to treat the Indian diabetic patients. This is my disclaimer. See, this is today's overall my presentation in next 20-25 minutes. I think I have enough time, so I will try to cover each and everything in detail because almost we are going to end the session. So this is my total overall presentations agenda. First, we all are following the ADA and ESD guidelines for the as far as diabetes management is concerned. But we Indian, particularly South Asian people, we are a little bit different. So I will say certain things about how Asian Indian people, they are different from the Western and Caucasian people, number one. Second thing, we Indian are consuming more carbohydrates. So we all know the dietary carbohydrate contains, they having a directly implication in the diabetes management. Third one, I will discuss, say about something of the PPG, postprandial hyperglycemia. This is a very important and burning issue when you are going to treat our diabetic patients. And what are the significance of the postprandial hyperglycemia management in our basically OPD-based practice. Fourth one, I will say the mechanism of action of the acarbose. And we all know acarbose is a natural incretin enhancer which having a unique insulin sparing mechanism of action. And after that, I will say something about the robust real-world evidence as well as RCTs, which is going to favor the glycemic control for acarbose. And on top of that, also I will go to share some data which are having a other than basically glycemic control benefit effect. So you can see here, this is the overall. Yes, this is a 25 of the acarbose journey in India. You can see here almost more than 600 clinical trial was happened. More than 2,000 the scientific studies was done. And particularly, acarbose is going to approve more than 117 countries across the globe. And almost you can see more than 70,000 patients they have studied across the globe. Among that, 48,000 people they have selected from the India from different trials. So it's a very trusted molecule. And you can see the acarbose is going to launch in 1987 in India. After that, there will be we are getting approval in even type 1 diabetes on adjuvant the diet as well as for the insulin therapy in 1999. After that, we all know the stop anhydride trial. It was done for the pre-diabetic patients. We are also going to get approval. This is the only molecule in OAD which is going to approval in the pre-diabetic patient. And that approval we are going to get 23 years ago in 2002. On top of it, you can see the things in 2006. We are going to approval in the IGT patients, which we are going to call impaired glucose tolerance patients. After that, in 2009, we are also going to get approval, and they will launch the fixed dose combination of the acarbose with the metformin. And back to back, we having a IDF also going to support a statement. You can use this molecule to treat your diabetic patient before the 12 years. And after the STAR study, we all know Dr. Sasank Joshi sir was the principal investigator for STAR study, and they have done the basically study across the basically corner of the India, and they have found that particularly India, we are consuming more carbohydrate. That's why we have to treat in a different way for our diabetic patients. The GLOBE study, I think Dr. Bansi Sabu sir is a principal institute for GLOBE study, and then they have come to know when you are going to treat your diabetic patients at the time of diagnosis, so acarbose and metformin is a good combination as far as the selection is concerned when you are going to take care of the PPG and fasting sugar, because in India we are going to see more and more diabetic patients when the entry A1 A1C level PPG is a more common factor. I think in next slides I will going to say upon that. So up till basically 20-25 years there will be a lot of the scientific data, and acarbose is going to study continuously with the lot of robust evidence-based the trials and the research is there, and it is going to prove the relevancy in terms of the efficacy as well as safety profile in the Indian population. And you can see here The starch aim study, there was a landmark study. It was done to evaluate the effectiveness as well as the tolerability of the acarbose and the metformin as a fixed dose combination in newly diagnosed T2 diabetes patients. Now let me go into share upon the few sentences how the acarbose is going to generate. See, the original carbos. Now also there are the other carbos generic available in the market, but I will going to say certain among the things. It's a manufactured by the Bayer company. Plant is available in Germany. Across the globe, none of the the country or the basically ocean, they are going to produce this original molecule. And it's a very clumsy and the complex process. Though the external process of the molecule like acarbose required the perfectly controlled condition. And how the Bayer people going to see, they are going to do the monitoring properly, and they are going to strict the monitor on the quality of the raw material, because raw material is very important thing. And when I've discussed with the pharma people, they also told me that ultimately the 365 days to be required to entire making this molecule process. So here the quality of raw material is very important, and then they deploy the meticulous particles and they are going to process in a proper way. So they are going to make it provide a highly the quality molecule. And why we have to trust on the quality of the original carbose? So acarbose tablet under the brand of the Glucobay is the original research product of the Germany. And you can see here the overall process performances and the product quality monitoring are going to apply to 4 stages of the product lifestyle, starting from the manufacturing side, to the vendor. You can see here how they are going to assess for the ultimately the packing, transportation, the overall goods available to warehouse as well as to distributor. So whole the things is going to manage proper way. So quality of molecule is not going to disturb, and ultimately doorstep patient will get the proper quality molecule. So this all about the primary information of the acarbose. Now already Dr. Mahendra Narwaya sir has discussed in the last slides the Indian phenotype, and sir also has explained the Bansi Sabu sir and himself the YY products like just sir also they both have explained. So there is nothing new, but we have to think our Indian patient or South Indian people in different way, because we are not just like similar like the Western population or Caucasian population. You can just see we are South Asian people, lean, thin Indian fats. So we are going to different from the Western people in which way that I am going to say here. We are having a onset of T2 diabetes at an early age, almost 1 decade early as compared to Western population, number one. Second thing, we Indian also having a high risk of the complication. Third thing, we having a loss of the first insulin secretion at the earlier age, and we having a higher beta cell dysfunction ratio. So looking together, we Indian patient little bit different from Western population. So definitely all the molecules having own role, but we have to think some different way when we are going to treat as far as the Indian patient is concerned. Second thing, we having a more insulin resistance, and over above patient having a more and more hyperinsulinemia, and because of that low level adiponectin and high level of the inflammatory mediators, we are having a more risk of the dyslipidemia as well as the cardiovascular disease or long-term way. So definitely we have to think our Indian patient in a different way when we are going to treat as far as the diabetes management is concerned. So treatment to be individualized, and as well as I think specific you can take a call. Now why the PPG? See, the fasting and post-meal both sugar is going to be contributing factor for uncontrolled diabetes. Now the guidelines also going to be changed. We have to just for the glycemic pentar, like fasting sugar, post-meal sugar, A1C level, even now the glycemic variability, and without risk hypoglycemia. So if you are going to take care of it thoroughly, then and then you can able to provide a good glycemic control and good clinical outcome for longer run way. So here, they have mentioned why PPG should be addressed for better diabetes management in Indian patients, because this is the 3 points we can say. We India are having a more and more carb consumption, and because of that we are having a more and more of the high PPG, and because of the high PPG, Indian people are going to having a more and more the early uncontrollable diabetes. Here look at the trial, the STAR study. It's a well-known study. I am not going to describe detailing, but STAR study reveals the overall Indian diabetic consumption diet across the carbohydrate. You can see here. If you are going to see here, you can come to know either you are going to any corner of the India, almost as per Indian people, we are getting the energy almost 60 to 65% from the carbohydrate. So healthy fats and protein is very less likely. And because of the high carbohydrate, we are having a more and more the post-meal glycemic excursion, and ultimately is going to translate the high post-meal hyperglycemia. You can see here, there will be a comparison done from the other country people also. But in Indian people scenario, you can see here, we are consuming more carbohydrate, and because of that, we are having a higher blood glycemic excursion after each meal, and we are consuming even 2 or 3 major meal also. So not only the post-lunch, We have to take the history when patient is going to come in OPD, which are the meal, which are the timing of the meal, compound of the meal, quality of meal, and accordingly you can basically treat in patient in a better way. And also the last corner you can see here, they have also observed when they comparison versus Japanese versus coconut people, you can see here, Asian people, particular diabetic type 2 patients, we having a insulin secretin deficiency, and because of it, this is going to happen in an earlier phase. So they are going to develop more and more post-prandial hyperglycemia at earlier stage, and because of that, PPG should be basically more addressed in a proper way in the Indian patient. Now, one of the slides you can see here. Here they have done comparison between the Western people versus the Indian Asian population. You can see here the over and above they have observed we are going to get the greater contribution from the post-prandial hyperglycemia in Asian people. Look at this slide carefully, you can come to know. Here the Western people at the early onset of diabetes even sees like 7 or 7.3 at that time we are going to get more contribution from PPG. But as soon as the A1C is going to become rising, higher the A1C, Western population they are going to get the more contribution from the fasting sugar. See the slides. Green bar is 10 for the PPG and the gray bar is 10 for fasting sugar. The as soon as A1C is going to rise, the Western population, they are going to having a more convenient fasting sugar. But look at the Asian population study, you can come to know any spectrum of A1C, either the lower A1C or the higher A1C, we are going to get the almost the equal and certain level higher contribution from PPG as far as the basically diabetes is concerned. So again in above, we have to choose a certain molecules which are having a tremendous capacity to take care of the post-meal sugar. And if you are going to reduce your post-meal excursion, on the indirectly, we are going to give the transfer benefit to take care of fasting sugar. So dear my friends, I would like to say here, don't take in that way, A carbos is only going to take care of the PPG. If you are going to reduce your post-meal excursion, indirectly patient is going to having a good fasting sugar control also. So with this, I would like to say that mechanism of action, how the A carbos is going to work. Ultimately, A carbos is going to primarily take care of the PPG level where is from originate. Look at these slides. What they want to say here. Ultimately, they have done a comparison with the placebo and what they observe. With the A carbos, it's going to delay the carbohydrate consumption. This is the main thing, and delay the carbos and absorption is going to be there. And because of that, it will going to reduce the post-meal glycemic excursion. And here, beta cell is not going to come exhaust. They will going to give the rest to beta cells, and ultimately, because of the insulin perimechanism action, ultimately protection of beta cells is going to be there. And here, it is going to improve the insulin sensitivity. And we all know A carbos is going to push the polysaccharides in the lower part of the intestine, and because of that, they will going to increase the GLP secretion after the 60 minutes of the digestion process going to start. And in the when the gliptin and the SGLT was not available, at that time AGI having a role, they are going to say the poorable gliptin, because now the generic gliptin is available, so cost is going to low. But when the innovative brand was sitagliptin available, at that time almost cost was 50 rupees per tablet. At that time, because of the AGI having beautiful effect, they are also going to label as a poorable gliptin. So this is having a unique mechanism of action, and ultimately glucose reabsorption is going to be decreased. And what is going to do AGI? AGI is going to ultimately inhibit the alpha-glucosidase enzyme. And we all know what alpha-glucosidase enzyme will going to do it. Ultimately, it will break the carbohydrate. And after breaking carbohydrate, it is going to break down to monosaccharides. But here, because of this unique mechanism of action, it is a alpha-glucosidase inhibitors, and that's why the glucose reabsorption is going to become reduced. And ultimately, it is going to target the post-meal sugar. So because of the unique mechanism of action, particularly A carbos, AGI is going to take care of the post-meal glycemic excursion. There are the other benefit, because of the insulin mechanism, this molecule you can use even CKD patient also. And we are having, I think my all colleagues and senior friends here, we are using this molecule, even irrespective to EGFR you can use it. There is no required insulin dependency, even though patient is going to having a better basically post-meal glycemic control. And because of that, we all know when we are going to insulin, certain times the risk of the hypoglycemia and weight gain is going to be there. But here you can see here, because of the insulin mechanism action, they are patient having going to transfer the better clinical benefit effect, and we can able to reduce the risk of the hypoglycemia. Not only that, we can also reduce the risk of the weight gain. Again, already I have mentioned the mechanism of action. Once they are going to delay the carbohydrate absorption, and because of that one, what is going to happen? You can see this slide carefully. It will going to stimulate the GLP-1 RA, and we all know what are the benefit of GLP-1 RA. After 60 minutes, is going to be because of the presence of the unabsorbed carbohydrate. Because of it is going to. You can see here what is going to happen in basically the A carbos, and without A carbos they have mentioned here. A carbos is delay the absorption of carbohydrate, and because of that there will be a large pool of the unabsorbed polysaccharides in the lower part of the colon, and because of that it will going to stimulate the GLP-1, and GLP-1 effect is going to transfer the benefit by all means what are we are going to see in our day in day out practice with the all other GLP-1, right? So this is also another benefit effect. So with this background and mechanism of action, I would like to say, is there any evidence or data for glycemic control for acarbose? Yes. Look at this slide carefully, you can come to know how the acarbose is going to efficacious to take care of glycemic control. We all know any molecule is going to available in earth as far as the oral drug is concerned for A1C reduction as a monotherapy that has to be proven to reduce the A1C capacity more than 0.5%. And here you can see here the acarbose having a capacity, it is going to reduce the A1C 0.8 milligram as a monotherapy. If you are going to use a 50 milligram TID, you can see here there is a pool analysis of the 28 randomized control trial, and you can see almost the more than 2,800 patients they observed there is a 0.8% A1C reduction was found out. Even the average fasting sugar is 20 milligram and post meal is 40 milligram. So this is again the beautiful information what they basically come to know. Again, the second slide, right corner, you can see it's a systemic and a meta-analysis of the 46 studies. And what they observe, they have comparison done between the Western diet and the Eastern diet. We all know, as far as the Eastern diet, basically we are consuming more carbohydrate. Western diet, basically there will be a more protein-based diet and the fat-based diet. You can see here, there is a directly basically going to more A1C reduction capacity in the Eastern diet as compared to Western diet. Almost the 1% A1C reduction was better in the Eastern group population as compared to Western population. So here there are number of the trials and studies going to be there. They are going to favor the acarbose as far as the Indian T2DM patient management is concerned is going to be more and more positive data. Here again the gluco-VIP study was done 2013, and you can see it's a multinational real-world evidence. And here, almost across the globe, they have done study on the 15,000 people. Among that, almost 1,916% you can see here, they have selected from the Indian patients. And it is a subgroup analysis of the Indian patients. And you can see here, there will be a remarkable improvement from the entry PPG or to fasting to, you can see here, almost there will be a 75 milligram average reduction PPG at the end of the 3 months. And here also 40 milligram reduction in the fasting sugar. So again, don't take in that way. AGI is only going to work on PPG. AGI is going to take care of PPG and fasting both. Again, it's a weight neutralizing agent. This is also the wrong concept. In certain people or group we have observed, it is also going to reduce the 2 or 3 kg weight also. So there are a lot of the benefit effect apart from the glycemic control that I am going to discuss in the basically next 5 minutes. So here you can see here the significant changes in the A1C level, fasting sugar, and the PPG. So almost basically this is again the beautiful information of what they've achieved. Again, this is a meta-analysis of 45 studies. Data was published in the journal annual of the Indian Medications. And here you can see here there will be a study done to evaluate the comparative effectiveness on the glucose lowering drug for T2DF patients. And here they want to see what is going to happen in the drug naive patients and what is going to happen when patient is going to receive the metformin back therapy. Here also you can see what is going to see when the drug naive patient also acarbose is going to show the 0.73% A1C average, just like the other basically GLP-1 or SGLT2. Almost AGI shows the comparable glycemic efficacy. Other patient is drug naive or patient is going to receive the metformin backline therapy. So there is again the proven data. There is no problem, and this is a good trial. Stop NIDDM. We all know the stop NIDDM trial. Ultimately, this study was done in pre-diabetic patients. Pre-diabetic patients when A1C between 5.6 to 6.4, we all know. And the study was done for the 3.5 years. And again, you can see here what is going to having a good information as far as the stop NIDDM trial. You can see here there will be a reduction in the incidence of the development of T2DM. So 25% reduction in the incidence of the type 2 diabetes. Not only that, they have also observed there will be a chances of the reversal of the pre-diabetes to normal glycemic control. This is a very wonderful information what they have received. So it is not going to reduce the progression of the diabetes, but also is going to reverse the diabetes. 35% there will be a increase the ratio of reversal normal glycemic control. And look at the p-value is also less than 0.001. So there will be any very good information. So this is all about the glycemic control. I will take basically few more minutes because the non-glycemic benefit also I will discuss here. Now the points is going to come. We are using the acarbose and voglibose. Now miglitol also is a company AGI, but unfortunately is not available in the market. So all our AGI is same. We are using the voglibos also with the frequent combination as well as a monotherapy also. But what are the basically is there any comparison? Yes. Look at these slides, you can come to know the comparative study was done in 2019. Here what they have done basically, they have just selected 2 arms. In one arm, basically patient was kept on the voglibos metformin, and second arm they have kept on acarbose metformin. And the purpose of the study just to evaluate the efficacy as well as the safety profile of the voglibos and acarbose in patient with a T2DM, those having a poor control on metformin. We all know AG having some side effect like the nausea, bloating, sometimes gastric discomfort, belching, or maybe diarrhea. But frankly speaking, as far as the acarbose is concerned, in clinical practice, we have observed if you are going to start with a little bit slow dose, like 25 milligram BID, TID, one person is going to tolerate. And if they require the PPG control, you can up to 50 milligram TID. There will be no any major GI side effect. In terms of the side effect is concerned, we have observed clinically voglibos having a little bit more side effect like diarrhea and the basically GI upset as compared to acarbose. Again, is to be individualized, patient-to-patient variability may be there. So what they observed, you can see the comparative data. The A1C reduction was a little bit better, 0.93% reduction. 14 milligram reduction in fasting sugar, and average basically 60 milligram PPG reduction is there. So here also basically there is a very beautiful data is there. Because of the structural basically uniqueness of acarbose is the only AGI that I already have spoken that allows going to more polysaccharide to large intestine and having a bigger molecule as compared to voglibos is a smaller molecule and it's having a pseudo tetracyclic quality. Acarbose is going to start from the oral cavity first bite. Usually we are going to advise our patients, if we are going to prescribe the plain acarbose, we are going to advise just you have to take with the first bite of food, either you have to chew. So it is going to work from the saliva itself, because here you can see they have done the comparison as far as the basically molecular science concerned with acarbose versus voglibos versus the miglitol. You can see here it is going to also inhibit the alpha amylase at the saliva level as well as the alpha inhibitor at the pancreas level. Here in voglibos and miglitol, we have no any data. And because of that one, it is going to delay the carbohydrate absorption from itself upper GI tract. So molecules work is starting from the beginning. Again, I have spoken, the voglibos, they having a very few data, and as a monotherapy, they having a capacity of only reduce the 0.5% ANC. And here, the acarbose, you can see there will be a 0.8% ANC reduction was there. So in terms of that, also the ANC reduction was capacity somewhat better with acarbose as compared to voglibos. So I think, say here one statement, A for A, means acarbose is going to for all. You can use this molecule, and we having a lot of data. Now we can having a, make it sentence, it is going to having a demonstrate the consistent glucose lowering efficacy across the broad range of patient population, irrespective of the age, irrespective of the background therapy, duration of or type 1 of diabetes, because now we are going to approval a type 1 also, T2DM only we are going to use, even in the pre-DM IGD also. Irrespective of the A1C, even irrespective of the liver and the kidney condition, you can use it. Only thing in the patient having those having a severe GID, IBS or IBD, better not to use. Otherwise, you can use this molecule basically safely. And irrespective of the condition of beta cell, you can use this molecule. So we are going to get approval in the IGT patients, T2DM, as well as the type 1 DM, and also is going to get tremendous capacity to significantly reduce the PPG. So this is some glycemic control, and I will spend only 5 minutes for the non-glycemic benefit control. So here the glycemic variability reduction, this coefficient variation benefit, and gut microbiota. Here you can see here when they done a comparison between the type 2 diabetes patient for the 20 weeks. One arm is a metformin and second arm is a acarbose. And only patient on the premix insulin. And you can see here there will be significant high reduction of the coefficient variation, mean absolute glucose expression, and standard deviation from the baseline with the acarbose with the insulin group as compared to the metformin group. You can see here this is the data. Is a very wonderful basic information what they've achieved. Similar way, again the GV, glycemic variability is the very biggest issue. Now we are going to see in our day-to-day clinical practice, not only type 1, also type 2 also. And when we are doing CGM, then we will come to know how the patient having intraday glycemic variability and internal glycemic variability. And here also they observe there will be a significant lesser time of the glucose level is going to remain above 180 milligram deciliter in acarbose arm as compared to the basically Vilda and metformin combination. You can see here hardly patient is going to remain the 8% time throughout the day in the time above range. Otherwise, basically you can see those who are treating with the metformin with the vildagliptin with placebo, there will be a 30% patient is going to remain the above target. Again, another study, they have observed it when they have comparison with the allogliptin, there will be a good post-meal glycemic excess reduction with the AGI as compared to the allogliptin. And apart from glycemic control, they are also going to capacity to reduce the cardiovascular risk factor. You can see here, the study was done in 2030, and they want to just assess the impact of the acarbose on the various severe risk factor in patients with diabetes IGT. And you can see here, there will be pool analysis of the 95 studies, and you can see it is going to not only reduce the fasting and insulin A1C, but is also going to have a positive impact on BMI and triglyceride and cholesterol level also. It will also going to reduce the basically other inflammatory markers, right? And again, there will be a positive effect on the basically the cardiovascular other risk factor in disease also. It will going to reduce the CV death, cardiovascular disease, risk of the myocardial infarction, and suboptimal disease. So there will be a lot of the positive benefic effect. And you can see here also, they will the comparison between the sulfur and metformin, they observe there will be almost 33% reduction of the stroke, 31% reduction of the CV events, as well as the 34% of the myocardial infarction. And last slides for the gut microbiota. We all know this, the gut microbiota basically is a very good things for the healthy guts. And here basically when the analysis, they will come to know, because of this going to pull the polysaccharides in the basically the large colon, and because of the fermentation of the production is going to be there, and that will produce the healthy gut microbiota, which is going to overall improve the health. So this all about the basically the acarbose. Because of the time concern, I am not going to discuss. Here we have done the CGP, and after the basically AGP, they have basically observed how it will going to take care of the variability and how it's going to take care. So just take home message. The STAR study is a, we all know, we Indian consuming high carbohydrate, and because of having a very high PPG and glycemic variability, now acarbose is officially going to approval in a IGT patients, type 1 patients on the diet plus insulin and T2DM. And it is not going to reduce only PPG, but it is also because of